Hello, it's Chris Beaulieu from Stanford University in California, and I'm happy to speak to you about groin pain in athletes. We'll consider some musculoskeletal disorders about the pubis called athletic pubalgia and so-called core muscle injuries. If you think about causes of pelvic pain in general, you can think of visceral causes, as we just heard about in multiple sessions, and also neurological causes, which I won't be covering. I will be talking about orthopedic issues about the pubic symphysis in particular, including muscle and tendon abnormalities and bony abnormalities. However, in general, if you have a patient with groin or inguinal region pain, keep in mind that the most common disorder is usually related to the hip joint itself, whether that is arthritis or an injury or things like femoroacetabular impingement and labral tear, as shown in this case here. You can also have traditional type inguinal problems like a hernia here, a direct inguinal hernia without bowel. Now, there's a concept of a so-called sports hernia, which is in the lay press, and it's a term I would recommend not using because it's really a misnomer. It's based on work back in the 1980s where it was recognized that some athletes can have a weakness in the abdominal wall, but without true herniation of bowel, and it was thought to be like an incipient or an impending hernia. And there is such a thing, but let me talk about that towards the end. Then in the 1990s, based on better MRI scanning in particular, it was recognized that there are a number of musculotendinous disorders about the pelvis and pubis that ended up getting lumped into this idea of sports hernia, even though those things have nothing to do with hernia whatsoever. So athletic pubalgia is a preferred term now, or core muscle injury. It tends to be groin pain that lateralizes to one side. It tends to be more chronic than acute and tends to involve male athletes more commonly than females, and usually involves running and cutting sports, such as you can see the amount of stress that would go on in the pelvic region in sports like soccer or American football or rugby. The anatomy is shown here with the bony pelvis and the rectus abdominis coming down from the abdominal wall, and it's going to come in front of the pubic bone here and be in continuity with the adductor. I'll show that more in detail in a moment. But it's right next to the inguinal ligament and inguinal canal here, and so that's all relevant anatomy. The pubic bones themselves form together to form the pubic symphysis, which is a stable fibrocartilaginous joint with ligaments above and below. It's ovoid in cross-section, and what I'll emphasize in this talk is the musculotendinous anatomy, where the rectus comes down, forms a tendon or aponeurosis, and is in continuity with the adductor longus and short adductors below, shown here on this cadaveric specimen. Rectus abdominis coming down to form this broad aponeurosis in front of the symphysis in continuity with the adductors. Another example here where the examiner is lifting up the rectus abdominis muscles, showing the aponeurosis here and the arrowheads, and then more aponeurosis here in front of the pubic symphysis in continuity with the adductors below. So when we image this area, we do a broad field of view overview of the pelvis, including coronal and axial images to sort of screen for any possible abnormality. However, I'll say that we don't consider this to be a full pelvic or a full hip examination. Those are separate protocols. For the pubalgia protocol, we do small field of view axial images as shown here, and we do small field of view sagittal images, where let me just point out the anatomy here of the rectus abdominis, muscle coming down, forming tendon, and then wrapping around the pubic symphysis, going inferiorly. We can't see the continuity in this midline section, but that's what we'll be looking for. Another great plane to do is oblique axial T1 and T2 fat suppressed images perpendicular to the pubic symphysis. That gives us a good look at the bony anatomy and the adjacent tendinous anatomy. And if you're interested in putting together a protocol for this, you may want to look at the articles, especially by Adam Zoga in Philadelphia. So what are the types of injuries that we look for? Well, there's bone and joint type injuries. So the pubic symphysis and bone adjacent to the pubic bones can have injury. So here's some marrow edema within the left pubic bone that can be seen as a stress reaction or sometimes actually a fracture. You may also see degenerative change in the symphysis itself and a cleft that forms there. Many of us as adults actually do have a cleft in the midline of the symphysis, but it shouldn't go off to the side like this one. The tendinous apparatus gets injured, and it gets things like tendon degeneration or tendinopathy and partial or complete tearing of these tendinous structures, and it may involve one or multiple of these structures. We'll look at these on MRI shortly. So here's an example where that aponeurosis, or the so-called pubic plate, this black structure right here, is just elevated a little bit off the bone, even though the other adjacent tendons are intact. If we look at that in a movie format, we're going to do oblique axial images, and scrolling through, you can see these are the origin of the adductor longus tendons bilaterally. This white fluid underneath the pubic plate is abnormal, so that's an aponeurotic injury, even though it's not like a discrete tear, it's just sort of lifted off. So that's a fairly low-grade type of an injury. We'll look at that in the sagittal plane. And so if I go over to the midline here, again, here's the region of the ovoid pubic symphysis, rectus abdominis, tendon, and here on the T1, T2, you can see that little bit of fluid underneath the pubic plate there. If we go off just to the side, I want to show you the origin of the adductor longus tendons here. So here's just off to the side, this triangular structure is adductor longus tendon coming off, nice and dark on T2 on that side. And similarly on the opposite side, see that adductor longus. Just follow along with that as I scroll back and forth. So that's important anatomy to look at. Of course, if you get all the way out to the hip joint, you can look for things like labral tear and cartilage damage, though again, we don't consider this to be a full hip examination. A couple of clinical examples then, and here's an NBA basketball player who has injury to the left side of the pubic region. Here's the adductor longus. This intermediate signal here on T2 is some tendinopathy and partial tearing at the origin of that adductor longus and along the pubic plate there. Here it is here on axial images. He's got some degenerative change of the symphysis with small cysts formed on each side. This tendinopathy, partial tearing on the left side, and to a lesser extent on the right side. A different athlete here, a younger patient who had a scan for a region in the region of the injury in the region of the iliac crest. He has what's called a secondary cleft sign, where, as I said, many of us will have a cleft in the midline that should be straight up and down. It shouldn't go off to the side like this, either to the right or the left, or sometimes both. That cleft indicates tearing of the short adductor origin. So if we look at it on axial images, the oblique plane will come through, and if we come from above, so here's the pubic symphysis. These are the adductor longus tendons there. Those are intact in this patient, but it's more inferiorly and posteriorly that you actually see this cleft off to the right side at the origin of these short adductors, leading to this so-called secondary cleft sign. These clefts are something that we talk about in MSK, and you don't really have to know those as a body imager, but it's worth perhaps knowing that the so-called secondary cleft is lower down, and that's related to tears of these short adductors, whereas the so-called superior cleft is higher up, and it's related to tearing of the adductor longus, and that would show up on a symphysis injection like this up higher under the upper part of the pubic bone. This is a more complex clinical case where the patient has multiple abnormalities. He is an ultra runner. Here's oblique axial section through the symphysis, bone marrow edema in the left pubic bone, some cystic change. There's intermediate signal underneath the pubic plate itself, indicating that that whole aponeurosis is partly lifted off the bone. As we go a little bit lower, you see focal high signal at the origin of the adductor longus on the right, and to a lesser extent on the left. And then even further down, postero-inferior, another one of those secondary clefts indicating tearing of the short adductors off of the inferior part of the pubis. Here on scrolling, you can see again going through, so from up above, here's the rectus are pretty much intact, some elevation of the pubic plate here, and then going inferiorly, abnormal signal at the origin of the right and left adductor longus. So here's the sagittal image, so here's the reference, and you can see focal partial signal at the origin of the right adductor, and this next slide, smaller amount of abnormal signal at the origin of the left adductor. So partial tearing, multiple different abnormalities, and in our report we would describe those in some detail and some specificity. So back to the inguinal canal. So we do get regular hernias, right? Traditional hernias that we see very frequently. That anatomy is immediately adjacent, all this rectus and adductor apparatus as well, so symptoms can obviously overlap from that. And it was Gilmore in 1980 that described this idea of the so-called sportsman or sports hernia, where it was an incipient hernia where they would open up the inguinal region and find a bulge, even though there wasn't actually bowel herniating through quite yet. But this, again, has nothing to do with those musculotendinous disorders. Do we see these things on imaging? Well, many places do ultrasound to look for this dynamically. We don't do that at Stanford. But I did want to show this case, which is subtle and difficult to illustrate, but it's of a professional football player who had pain in the right inguinal region and kind of a funny look in the superficial inguinal ring here on the right. And there was a small rent that may be difficult to see in the posterior aspect of the inguinal canal here on the right, indicating focal herniation of fat that had occurred fairly acutely, and that fat was a little bit edematous. It was actually an acute onset of a small direct inguinal hernia. Here's a bigger example in an older patient of fat through a direct inguinal hernia. So summarizing things, this groin pain or athletic pubalgia is an important syndrome. It has somewhat complex MSK anatomy, but if you look for abnormalities about this area, it's worth doing on your pelvic scans. Mainly these myotendinous structures about the pubic bone and pubic symphysis. There is some interaction with traditional hernias, but I would recommend avoiding the term sports hernia. So if you're looking at scans like this, whether for MSK or in body imaging, look at 4 different types of things. Look at the bones and the symphysis for inflammatory change or degenerative change. Look at the pre-pubic aponeurosis in front of this symphysis. Look at the adductor longus apparatus and the short adductors for tendinopathy and partial tearing. So there's some references here. I hope that they're helpful. You may have to zoom in to see those, but that's it. And I really hope that you've enjoyed this presentation this morning. Thank you so much.